There we go. See the sign? We're being recorded. So happy Wednesday afternoon and welcome again to our Wednesdays at noon. And today we have two presenters. The first presenter will be Dr. Jennifer Lane. And then following that, we will have Heather McDougall present. So Jennifer, whenever you're ready, you can share your screen and look forward to your presentation.
Thank you. Will you tell me if it's, make sure that it's not my presenter's screen?
Yeah, looks good.
That's
Perfect.
good.
All right. Great. Well, I'm here to talk about my current projects. I'm going to try to get it in about 20 minutes so there's time for questions. We have funding from DAL, Research Nova Scotia, and CIHR. The title of the project is Advancing Health Equity in Nova Scotia by Exploring Gaps in Healthcare Delivery, which is far too long. So instead of referring it to it in its long title, we created an acronym. And so we refer to it as Project Adding Heat. Our team is very big, and it needs to be. It's a complicated project, and so we need lots of areas and kinds of expertise, including lived expertise and knowledge. So aside from me leading the project, there's no hierarchy on the team. We all connect on the same level. There is a core team, though, which is me and my mentors, research staff, and a couple others who are partners or academics that are sort of needed in a greater capacity than the partners and academics who aren't on the core team. So our team is motivated by shared experiences of persistent health disparities rooted in systemic inequalities that are disproportionately experienced by the groups and communities we belong to. We see efforts being made to address health disparities, and yet they persist. So we're working together to advance health equity in the province. The diverse population of Nova Scotia, particularly those experiencing health inequities, holds valuable knowledge that can be leveraged to address systemic gaps and advance health equity by prioritizing the insights of equity-denied groups, but it is a broadly inclusive project. So anyone living in Nova Scotia who is 16 years of age or older is eligible to participate. Key input of the study is that the majority of our team members belong to equity-denied groups. And so this uniquely equips us to know how to access the knowledge of individuals belonging to equity-denied groups and how to leverage it to promote equitable change within the health system and Nova Scotia more broadly. So the project has 3 phases, and it's going to take 3 years to complete. Our objectives align with the phases. So the phase 1 objective is to create an inventory of Nova Scotia relevant knowledge that relates to health equity. And then phase 2 objective is examining the integration of health equity in the Nova Scotia health service and delivery systems. And then phase 3, we're using study findings to inform recommendations on how healthcare delivery can be more equitable and to conduct future research on advancing health equity in Nova Scotia and beyond. We're using mixed methods to answer our research question, which is how can health equity be advanced by identifying and exploring gaps in healthcare delivery. It's an intentionally broad question because we want to be able to explore it as broadly as possible. So intersectionality theory is central to how health equity is integrated into our project because it uses social distinctions to understand contexts of power. So the more differences we explore, the more predictions we should be able to make, and the more groups and individuals will benefit from the research that we're doing. This way of thinking pushes us beyond simply looking at the outcomes of individuals and even populations, but to use those outcomes to understand how power relations operate so we can learn how to work within them and change them. So just to touch on the sex and gender-based analysis plus, this is the graphic illustration used by the Government of Canada to depict the concept of intersectionality and some of the identity factors that can be used in an SGBA plus, which is the government's attempt at essentially mainstreaming intersectionality theory across federal public service departments and agencies. The literature on the SGBA plus is critical of how intersectionality theory is being implemented, because explicit attention to how identity categories engage with those broader systems of power is often missing or diminished. So the focus can be on individuals or even population level, and indicative of what can be a reductive application of intersectionality theory. So I use intersectionality theory in a way that sort of insists on contextualizing identity within broader systems of power. So without that broader engagement, it may be intersectionality as a concept, but it's not intersectionality theory. So an SGBA plus can include any and all of these categories, but when Indigenous peoples are included, there are additional considerations that need to be taken into account. So we have a working group that kind of operates independently from the team that's responsible for making decisions about how Indigenous peoples will be involved in adding heat. I'm the only non-Indigenous person in the group. The group gives me direction and I carry it out. So it's included lots of learning with REB, because they ask if Indigenous people are part of the project, if they're involved. And if you say yes, then there's this required documentation of consent. So I kind of had to push back on that, because my team members had plans on how they wanted to engage their own communities. So I didn't want to go back to them and tell them that Dal was telling us how to do that. So just trying to navigate that and protect people's right to self-determination. So our biggest challenge really has been figuring out how to apply OCAP to this general population study. Unfortunately, there's not much guidance out there on how to do it. So we're trying to engage people with the expertise to offer us the guidance we need to make sure that we're doing it respectfully. So for those who aren't aware, OCAP is the registered trademark of the First Nations Information Governance Center, and a set of principles that reflect First Nations communities' commitments to use and share information in beneficial ways while also minimizing harm. It stands for ownership, control, access, and possession. Because our research is being done in McDougall, it's OCAP that we need to think about. So I started digging into how intersectionality theory can be operationalized when I was doing my PhD research. I wanted to use it to understand how primary care was being delivered to 2S LGBTQ populations in Nova Scotia. So I'm going to kind of walk you through a part of that journey just to give you a sense of how we got to where we are with it in adding heat. So first, I complicated the category of 2S LGBTQ simply by recognizing that 2S LGBTQ is actually a consolidation of different communities with diverse needs. And then, of course, within 2S LGBTQ populations, there are more differences to tease out of each population that comprises the 2S LGBTQ community. So this is how I created points of comparison that I used to generate the sex and gender-based analysis plus that was used in that study. So I started thinking about how the limitations, there's limitations of only looking at the oppressed side of power. And if that meant maybe we were leaving practices that uphold cultural supremacy somehow unquestioned, and maybe limiting the engagement with those broader systems of power and analysis of them. So to generate an analysis of broader social structures, I wanted to look at both sides of power to understand how they sort of hold each other up, to get the kind of full picture, the fullest picture that I could get. So I realized that we can actually use the study population to do that. So to get a better understanding of how power relations were influencing primary care delivery, I included non-2S LGBTQ health service providers in the study population to be able to engage that side of the power balance or imbalance, in addition to 2S LGBTQ health service providers and health service users. So in addition to sexual orientation and gender, I adopted race, disability, and citizenship. And these points of comparison on either side of that social binary can be collapsed and form what I describe as a sampling framework. So the sampling method that has evolved for Project Adding Heat, it's a framework that we're calling a context-specific health equity lens. So instead of using these 5 social categories, we actually have 12. And so these are the categories that we've adopted into what will be our sex and gender-based analysis plus. And once we adopted the identity categories, we kind of explored which subcategories should be adopted, because the more differences we capture, of course, the more complex our SGBA plus will be. So our health equity lens, as we're calling it, will allow us to conduct a focused investigation of the health system, but it's also going to allow us to tailor study outputs to Nova Scotia subpopulations, sort of according to the needs and gaps we identify in the study. So we'll be testing out a new data analysis method as well that will allow us to carry out this focused assessment of the health system. And so more to come on that one. So we developed the health equity lens in phase 1 through community engagement. So we did this by, so a preliminary set of identity categories and subcategories were adopted through initial discussions with the team, and then were used to create a set of these socio-demographic questions that all prospective participants would eventually be required to answer. So the relevance of the identity categories and subcategories were explored with members of various equity-denied groups via a series of community networking events that were led by research team members belonging to said groups. Those who attended were asked to answer the questions and provide feedback on their inclusiveness and respectfulness, in terms of sort of capturing all important aspects of identity-related health determining factors. So each time the feedback was used to revise the socio-demographic questions, and changes were iteratively made to the health equity lens. This required a lot of work to happen in a short period of time. In a related project, we did a general engagement event that involved members of various communities, and we piloted the socio-demographic questions. Our Indigenous engagement was and continues to be led by the working group, and it's operating on its own sort of trajectory. The first Adding Heat event was the youth event at the end of February. I led the 2S LGBTQ engagement and co-led the disabled engagement after that, which was followed by ANS engagement, African Nova Scotian engagement, led by African Nova Scotian members of our team. And the last event was May 18th. It was the Arabic speaking newcomer event, which was really kind of cool because it was all in Arabic and I had a translator translating into English for me. So in about 8 months, we organized 8 events and engaged 109 people. So phase 1 has also included a scoping review that we have published in JBI Evidence Synthesis. And we're currently focused on recruitment. So in phase 2 efforts. So the survey, the data collection is ongoing. We initiated it in August of 2024, and we're doing these monthly audits to monitor the diversity within the sample population, and this is going to inform targeted recruitment. So this is the sample population as of the 5th of this month. We're at about 100 or 850 people, which is about a third of what we need to get our margin of error down to 2%. So this shows our overall progress, considering our target sample size is 2,395. Our goal is to meet a threshold for these subgroups in the sample population, and the thresholds are estimated based on the composition of the Nova Scotia population. So while we're still off on some of our targets, most of our targets, we've met them for gender diverse and sexual minority subgroups. And so we'll be carrying out recruitment to try to meet our targets for these underrepresented subgroups. We'll be doing targeted recruitment. So 0.5% of the Nova Scotia population is gender diverse. So not a difficult target to meet. We surpassed it right from the get-go. And despite the increasing number of participants in our sample, we've been able to maintain it. Sexual minorities, it's 4% approximately of the Nova Scotia population. We have been over and above that target, well above it. And despite that increasing number, again, we still have been able to maintain that over, I think we're at 26% now. So I have a preliminary analysis of some of the survey data. We've got a ton of data. So I wanted to put something together just to give you an idea of how we're using social binaries to explore outcome variables. So this is the data that we'll use to understand the needs of the subgroups so we can tailor those study outputs accordingly. We'll be investigating the health system using the set of questions that comes after the quality of life questions, and that data hasn't been analyzed yet. So we're using the World Health Organization Quality of Life Scale. Quality of life is defined as an individual's perception of their position in life in the context of the culture and value systems in which they live, and in relation to their goals, expectations, standards, and concerns. So we're using the short version because it's just 26 questions, which is more reasonable than 100, particularly since there are multiple sections to our survey. So the scores are out of 100 and none are above 65. So not great. The age binary that we created shows scores that are almost exactly the same. However, this is one of those subgroups that we're well below our target. We only have about 10% of what we need. So that translates to about 150 participants. Age is a particularly hard one because 60% of our population is either youth or older adults. So it's a target that we'll probably struggle to meet, but it's okay if we don't meet it. We just have to be transparent about that generalizability piece. So the citizenship binary that we've created shows scores that are also pretty similar. However, this is one of the subgroups that we've only reached about 40% of our goal, and that translates to about 100 participants. The sex binary, slightly different. This too, though, is one of those subcategories. We're about halfway to our goal, so about 651 participants. And so, you know, that may or may not be representative of what's actually happening in Nova Scotia. We'll see how that evolves. The race and ethnicity binary that we've created shows scores that are also slightly different, but again, may not be representative of what's happening in Nova Scotia because we still have a ways to go to reach our goal. We're about 2/3 of the way there. So about 260 participants are in that equity denied side of the social, that binary, those binary categories that we created. Sexual orientation binary, it may be more representative of quality of life for sexual minorities in Nova Scotia because we've doubled our goal, and that translates to about 200 participants. Disability, this is another challenging target to meet. I think it's 38% of Nova Scotians self-identify as disabled. So it's interesting to see the relative difference, though, between these quality of life scores. We've just reached about 30% of our goal, so about 200 participants. And scores for gender, these are the most different. And we've well surpassed our goal. So this translates to about 140 participants. And like that sexual orientation subgroup, this may be more representative of quality of life for gender diverse people living in Nova Scotia. So to contextualize the survey findings, we're going to be exploring them by conducting interviews. People can express an interest in doing an interview, either individual or group, when they fill out the survey. And so we're still in the process of selecting the participants for the interviews. Group interviews are easier. We've just barely reached the 30 people we're looking to recruit for those. So that's fairly straightforward. And the individual interviews are a whole other story. Almost 200 people have expressed an interest in doing an individual interview. So trying to select the 30 that will give us the most diversity within that sample is anything but straightforward. But I think it's the best problem a researcher could have when we think about how difficult recruitment can be. So next steps, we have to finish that scoping review. We have to conduct interviews, and we're going to be carrying out targeted recruitment via community engagement. And during those recruitment events, targeted recruitment efforts, we're going to take preliminary findings and get feedback from communities, get them sort of validated, get feedback on how we're presenting it, and that sort of thing. So that is Project Adding Heat. If folks have questions, I'd be happy to take them.
It's a beautiful presentation. Your presentations are amazing. I'll start off. I just have a question, and I'm just interested in your take on when you speak with your participants around the topic of intersectionality. Do they understand, or do they see how they have, like, can they connect with intersectionality? Like, do they identify that there's more than one category that they may be impacted by, or do they often, or is that something that they're not aware of? I don't know if I'm articulated well, but I know many may identify with one, but not realize that there are other aspects. Do you sense that with?
Yeah, I think we all have some sort of combination of understanding of how our identity impacts our experiences in the world. So I don't necessarily directly talk about intersectionality. I just assume that that person is speaking from their experience. And so it's a real organic emergence of intersectionality. And as long as that diversity is in your sample, you're addressing intersectionality to whatever degree your sample is diverse, kind of, if that makes sense. But
Yeah.
I always struggle because I feel like people always focus on the oppressed side, and no one is only oppressed or only privileged, right? So just looking at how the intersections are, a combination of all parts of our identity is, it's just such a cool lens.
Yeah, very cool. Thank you.
Yeah, of course.
Okay, I'm not seeing any other questions. So Well, thank you very much.
I have a quick question.
Oh, you do have a question. Okay.
Yeah, and it may be something I missed. So thank you very much. It's like a very interesting, very big study. So I congratulate you and your team for taking this on. I was wondering, and I may have missed this at the beginning, but for your recruitment strategy, are you going to be looking at like recruiting a distribution of people who reside outside of HRM as well? Just because I know kind of that could bring about some differences. But yeah, just curious about that. And again, thank you very much for the great presentation.
Yeah. Oh, yeah, my pleasure. Yes, so that is one of the considerations because place is one of those categories, right? So because the study is based in Halifax, we need to work harder. So excitingly, I've recently got buy-in from the community health boards. And so they've agreed to share information about the study through all their like social media accounts. And I could tell the second that they started sharing, because all of a sudden it was the majority was coming from outside of Halifax County. So that's really cool. The thing that we're trying to kind of reconcile now is that Halifax County is really diverse. I live in Bedford, so Cobequid is right there. Tertiary health centers are kind of at my fingertips. Ecum Secum is in the same county as me. Like that's just such a different experience. So we're thinking of further breaking down county to by using postal code, because we're also collecting that, but we're sorting that out. It's kind of a figure it out as you go situation, which makes it fun.
Great. Thank you so much, Jennifer. Very exciting. Okay, so Heather, are you good to share your screen? And okay, great. And whenever you're ready.
I think so. I will.
Yep.
Thank you, Jennifer. It's kind of intimidating to follow that. Not gonna lie. But I'll do my best. So here we go. Let's share this. It's a bit of a different line of project that I'll be doing here.
Yep, I see it there. Perfect.
But probably let's show.
There you go.
There we go. Everybody can see that and hear me?
Yep, it's all good. Thanks.
Perfect. Good afternoon. Thank you again for sharing and having me present here. My name is Heather McDougall, and I am a research coordinator for Elaine Moody, Dr. Elaine Moody in the School of Nursing. I'm here to present on meaningful activity for people with dementia with acute needs, exploring the role of activity in the hospital setting. So just a bit of background. Our population is aging. I'm sure that's no secret. And as of 2021, so that's 4 years ago already, 19% of the Canadian population was over 65 years old. And within this, there is an increase in the number of people who are living with dementia. And currently, as of January 2025, Alzheimer's Society had noted that there are over 750,000 people living with dementia. And it's getting closer to 800,000. So people living with dementia often have increased health and social care needs, and that includes hospitalizations. And those can be planned, however, they're often unplanned. Older people living with dementia are hospitalized at higher rates than older people without dementia. And the admission is actually often for reasons other than dementia. So it could be related to the heart or infection, for example. And sadly, our acute care system is not really designed to provide comprehensive care for people living with dementia, because the acute care system is designed to treat a short-term illness or to alleviate symptoms of a chronic condition, assuming that the person that is in acute care will be restored to health or significantly improved so that they can return home within a few days. However, it's often more complicated with people living with dementia. For people living with dementia, a hospitalization can be difficult. It's disruptive to patterns of life. The hospital is new and loud, and often things are not labeled very well, so it's quite confusing. It can result in temporary or permanent decline in physical or cognitive abilities. And many people living with dementia also can experience delirium, which is short-term confusion or lack of awareness, and that can be very quickly to come on or within a day. And also responsive behaviors to their environment. So actions, words, gestures, in response to things that are confusing, frustrating, or uncomfortable. All things that are very popular in the hospital setting. So all people, everybody who is in the hospital has acute or has non-acute needs, so psychosocial needs while they're in the hospital. So that could mean needing assistance with your activities of daily living. Everybody has to use the washroom or eat, have nutrition. And for the person living with dementia, they may need additional help or all help with things like that. Another issue is social isolation. So many hospitalized patients will engage in activity. I mean, you go through the hospital now and you'll see people with laptops or cell phones or a book, depending on how ill they are. However, people living with dementia often are not able to initiate their own activity or express that desire to engage in that. So our study into this, the big question is why? Why study activity? Because you're in the hospital, you're not going to do a lot of activity. But why study activity for people living with dementia and acute care? This idea for activity in acute care came from our study our team was working on, funded by the Alzheimer's Society, looking at how to better understand the context of the hospital environment in relation to nursing care for people with dementia. And I myself worked closely with this interview data, and my lens looking at this qualitative data is, while I work in the School of Nursing, my background is kinesiology, and I worked in long-term care for a number of years as a recreation worker. So I have that lens. And while we were looking at this data, looking at the hospital context in terms of nursing care, we noticed that there was a lot of references to activity or the lack of activity for people living with dementia while they're in the hospital. So as an offshoot of that initial study, we pursued this. So the study included qualitative semi-structured interviews of people living with dementia who had a hospital stay, their caregivers, or not specifically the people that we interviewed. There was one dyad of a caregiver and a person living with dementia. And we also did 2 focus groups with nurses and a couple of interviews. So these interviews focused on the contextual barriers and supports for adopting ways to improve the care of people with dementia in the hospital environment. For our study into activity, we used interpretive description. So we looked at a complex experiential question. So what are the activity needs of people with dementia in the hospital? And to provide practical applications. And it's also important to note that this study was planned before COVID happened, before we knew about COVID. However, the interviews, many of the hospitalizations happened during COVID. So it has that added layer to what can happen in the hospital. So we took the interview transcripts and we looked at them again, asking the questions, what are the needs of people with dementia, or sorry, what are the activity needs of people with dementia in the hospital? And also, how are they currently being met? In our findings, we found three broad themes related to the activity needs of people living with dementia in the hospital. So we found the need for social connection, the need for physical activity, and also the need to participate in recreation or leisure activity. And so while I'm going to talk about these three themes separately, they are all interconnected and reflect altogether the experience for people living with dementia in the hospital. So first, there's a strong argument for the therapeutic role of relationship or social connection, and its role in person-centered care. So nurses are there is a focus on person-centered care. But in our data, we found that this social connection was expressed in two ways. So firstly, when nurses, not just nurses, but when staff entered the room to do care, it wasn't just about coming in and giving them their pill or doing some sort of task, but initiating some sort of interaction during that task. And many of the caregivers noted that this didn't happen. There needed to be, they wanted to see interaction, like don't just come in, do your task and leave, like say, hello, hi, my name is, engage in a little bit of that interaction, even if that person who is in the hospital bed can't interact back with them. And secondly was a connection with family and friends. So family can bring stability, familiarity, comfort, and can reduce symptoms of dementia, which is often anxiety. Can experience that in the hospital regardless. And so that could just be the physical presence of the family with them, being able to, as the nurse, recognize the calming, being able to orient them. And it could also, we found examples of technology being used. So a phone call from either the nurses or being able to talk to them on the phone and say, hey, we can't come visit right now, but talk that out, and it did reduce some of that anxiety. So having that social connection and not being so isolated and alone in the hospital. Secondly, we noticed physical activity. So there are known benefits of physical activity while you're in the hospital. So that could just be the use it or lose it, maintaining function. It can also help reduce the risk of delirium and result in earlier discharge. So, I mean, there are programs in hospitals to get people up and moving after certain conditions or surgeries or just being up and out of bed. So we found this also there were two ways of expressing this. So rehabilitation and maintenance. So being able to get people up so that they can keep that, especially older people who may not move as much. And also just moving as a response to physical or emotional stimulus, so that need, which is often expressed for people living with dementia. So unfortunately, the rehabilitation and maintenance side, it was often noted that this was resource dependent, and sometimes hospital policy excluded certain populations or conditions. It was often noted that hallways, I mean, if we've been in hospitals, they're not necessarily a ward might be one long hallway. That's not the most appropriate place to walk all the time. There are things in the way. And often people living with dementia will need someone to walk with them, either supporting them or just as a means for direction, and that's resource dependent. And again, as I said, it's moving or restlessness can occur with dementia, and people may wander, and this could be problematic on a hospital ward. They may wander into or walk into the wrong room. So they may have to have someone in a specific location, so they can't leave their room to move. But it was also, on a positive note, noted that the caregivers and nurses did recognize the importance of this and tried to accommodate it as much as possible. So taking people for assisted walks, encouraging people to get up. So it was a balance. There were a lot of negatives and there were some positives. And finally, participation in recreation or leisure activity. And it was noted that it keeps them going. That was mentioned by a person living with dementia. So just like everybody, people living with dementia in all stages enjoy participating in recreation or leisure activities. And as I mentioned earlier, they just need someone to initiate it. And it was often noted that caregivers, if they didn't initiate that, didn't bring anything in, that person living with dementia who is in the hospital would just be there doing nothing. And they did note that if people didn't have visitors, they saw other people living who were in the hospital, they didn't have any engagement, or there was nothing there. So even if it was, pardon me, having a visitor, or going for a walk, or reading a book, or music was brought in a lot, and that was a big activity type thing that was mentioned. And there are some of these things available in the hospital, but not in acute care. It's not as prevalent. So, and people living with dementia, as the last quote from a caregiver says, they may not actually need a lot of acute care, but they're not well enough to go home, and it's not an ideal place for them to stay without some sort of stimulation. So and we looked at the activity needs of people living with dementia, and we find that they need social connection, physical activity, and the option to participate in some sort of leisure activity. And this is similar to other literature. However, there's not a lot out there, but it's related to personhood, unmet activity needs, and value of that person. So person-centered care. There was a few mentions to therapeutic recreation and music therapy. And so some of the nurses and caregivers mentioned this, that there was nothing there. And because their family member living with dementia some of them had already been in long-term care, they noted that this is something that does occur in long-term care. So therapeutic recreation is a systematic process that uses recreation or activity interventions to assess needs of people as a means to improve or maintain psychological, physical health, recovery, and well-being. And that's there are national councils for therapeutic recreation. So it is used in acute care. There are examples, I mean, on pediatric wards or mental health units. That's where it's quite popular. But it is growing in recognition for preventing or limiting behaviors associated with dementia, and also just in delirium for other patients on wards. We do have some local examples. There are departments at the Dartmouth General Hospital, recreation therapists, and also I believe there are some There's a program at the IWK as well. Nova Scotia Health started a new program called the Early Mobility Program to get people identified as frail up and moving, and that could include people living with dementia. So the role of therapeutic recreation is well established in long-term care. It is recognized as part of the interprofessional team. So with these findings, we thought, what next? There are a lot of people with dementia living who are in the hospital. So we can highlight how nurses can integrate relational nursing care. So using that active listening and empathy, taking that time to just have a really short conversation when you go in to deliver care, but also activity into care. So having a toolbox of say, oh, this person has liked music. Let's, do we have an iPad that or a phone that we can play some songs for them that they might like? And also just highlighting that the value of the interprofessional team, and maybe there is a need for therapeutic recreation to expand into caring for people living with dementia while they're in hospital. So they're just a new direction for research. And that is what we found when we interviewed people who had experiences in the hospital. I will stop sharing.
Thanks so much for your presentation, Heather. And I mean, I still do shifts at the emergency department, and it's very problematic there, and especially because not often they don't always come with a family member. Like if they come from long-term care facility, as soon as they have a bed, the medics that were with them are gone, so they're on their own. They wander, the confusion, and it's very difficult to manage their care in that setting. And it's so problematic that it's not like an occasional occurrence. I would say that's probably a daily occurrence that this happens. And I'm so happy that you're focusing on acute care settings, because it's probably one of the most challenging environments to be able to deal with these individuals. So so thank you for this work. Very interesting and so needed.
You're welcome. Yeah, it's very interesting also because there are like one-to-ones or sitters. Like that is yeah. There's so many terms, and I don't know if I really like any of the names, but they talk about that. There are a few of the people that was mentioned in the interviews, and just how varying that could be, because there were some people who did have one-to-ones or like sitters with them, and they were amazing. They knew how to interact with the patient and with the person living with dementia. Like they just, and then there were, on the flip side, other people who they're just being paid to watch them. That's all, like they just sit there, and you're like, well, yes, that's what you're being told to do, but
yeah. And in some situations, it can actually exacerbate the situation for them, because they see them as, like, some think they're still in their house, and they're wondering, why is this person in my house, or why, what is happening? So, there's, some sitters we do have sitters in emergency when they're available. They're not always available. And I know some use like the bed alerts if they're trying to climb out of the bed, but it's very Band-Aid measures, I find in emergency. There's nothing really to mitigate. It's based on if the situation escalates, or it gets to the point where we can't, keep them safe. And that's usually the issue, is them climbing out of the bed, wandering out, because not all our doors lock, so they wander and they're gone. And so it's it's just such not an ideal place to have them. So anyway, not that I have a solution, I don't, but I'm just saying it's a very prevalent concern.
Mhm.
Oh, Margot, I see your hand up.
Thanks, Heather. I just had a question, and thinking about people who are in hospital, typically they're for other reasons, for chronic conditions or instability. And I know people are there because there aren't placements for them as well. But I did wonder, given you're looking at activity level, if you also looked at their condition that might impact activity level, while in hospital, because it might be different than in a long-term care facility.
Yeah, and there were varying, like, some of the interviews that we conducted, like this wasn't even the main focus of the interviews. It just naturally, we just wanted to know what they're basically asked, what was your experience in the hospital? How did you find the nursing care? Like, that was kind of the focus of the initial interviews. And I know as I was reading these transcripts, I myself, because I have that background, looked at, and I'm like, there's a lot of mention of activity here. So we didn't, I guess, look at those diagnoses, like that wasn't, we didn't look specifically at that, but it was just at the different types of, yeah, because some people had different conditions that, yes, they couldn't physically get out of bed, that, they were bedbound, but then, like, it was even just they're isolated, they're stuck in their bed. Is someone coming to talk to them? And I remember, like, I read these a lot. So, there's mentions of people just sitting in bed staring at nothing all day because there's no family that can come visit them, and they don't have a book, or maybe they can't initiate something for themselves, so they're just sitting there. And yeah, so no, we didn't, but there were different people that we interviewed that had different levels.
Thank you.
Is there any indication of where are many coming from long-term care, or are they coming from home?
I think most of the people that we interviewed, they actually came from home.
From home, okay.
Wasn't, I don't remember if, I'm trying to think if there was anybody that came specifically from long-term care. There may have been a couple, but the majority of people came from home.
From home, okay.
Yeah.
Thank you. Noah.
Thank you for your presentation, Heather. It really resonated because before I started my graduate school, I did a stint in charge, and I remember just being constrained by the system. You're advocating for the needs of people, but you really can't. There's no solution that is available to you to help mitigate those concerns. So I know your study was in the context of nursing, but I can't help but think how relevant this would be for other disciplines, such as yourself, like recreational therapy, physiotherapy, even physicians. Those little encounters are often understimulating and very brief, but I think this has a lot of interdisciplinary connections to kind of make a bigger impact. So yeah, thank you so much.
You're welcome. Yeah, as someone who doesn't come from a nursing background, and I did recreation, but I'm always fighting for, like, this is an important thing. And if you can't, people, they don't have phones in hospital rooms anymore. Like, you can't just pick up a phone and call someone. You have to have your phone with you because pretty much everybody has cell phones, but that may not include that demographic. So yeah, just very interesting. So I'll keep plugging along.
Great. Thank you so much, Heather. And yes, please keep plugging along because this is very important research. So anyway, thank you to our two presenters and for everyone that joined us today. and enjoy the rest of your day. The sun is out, so enjoy. Thank you. Bye-bye.
Thank you. Bye.